Thank you very much for the kind introduction. Yes, so for those of you who already attended the poster session, I'm sorry, but I'm going to do another short introduction to HIFU. So in HIFU, we use actually ultrasound to create small volumes of rapid heating and induce thermal effects like tissue ablation for temperatures larger than 56 degrees or mild hyperthermia, as well as drug delivery. The heating volume, the heating volume is relatively small, but we can increase this treatment volume by coordinated phase shifts of the single ultrasound elements in the transducer and by mechanically repositioning the transducer. Image guidance in this technique is often done with ultrasound because it's a good fit, because you can always treat what you can see with ultrasound. But we at the UKK use MR guidance because it gives us some advantages in the visualization of the target volume and also gives us real-time temperature feedback. Additionally, we can, in the end, verify treatment success by contrast-enhanced scans and other diagnostic scans. So, as Professor Datta already said before, pancreatic cancer has a really high mortality attached to it, and it's particularly bad in Europe. So here we have actually pancreatic cancer at the 4th place in terms of mortality compared to other cancers. And if the current trends hold up, we will probably see pancreatic cancer advance to 2nd place by 2030. This is mainly because, so this bad diagnosis is based on a couple of different factors. It's a combination of the low incidence, which makes screening really ineffective. The symptoms are occurring late and are rather unspecific, which in the end leads to very few patients actually being eligible for resection, which is the only curative approach right now. So in the end, more than 80% of patients will actually end up in palliative treatment. These patients will then have to deal with symptoms like jaundice by obstruction of the bile duct, pain due to pressure on the nerves, and symptoms like vomiting or nausea because of pressure on the stomach. And if you're at home in the field of HIFU, you know that this is actually the home turf of HIFU because it's very well suited for reduction of treatment volume non-invasively and ablation of nerves. So there have been a couple of really great studies already coming from China since the beginning of the century. And recently also we Europeans started to catch on. This is some data from a very recent study from Bonn, actually near Cologne, where they could really nicely show that they can induce long-lasting and immediate pain relief as well as reduction in tumor volume. For a good overview, there's also a review published recently by Dabado, which I can very highly recommend reading. And in terms of survival benefit, we also see a potential, but unfortunately this particular study didn't have a control arm, so we cannot say anything definitive yet. So the most of these studies that were done until now were done under ultrasound guidance, however, and that means that there was no online temperature control, and that might help us in the future to more tightly control what actually gets ablated during the treatment, and will help us in more accurately pinning down where, for example, the pain relief comes from. So again, so we have some advantages in using MR for our treatment planning and monitoring, and just as in ultrasound-guided HIFU, we still have some remaining challenges, which have been pointed out during the lunch session yesterday as well. In HIFU, we cannot really go through the bowels most of the time because there's air trapped and other materials, and we still have motion due to breathing and peristaltic motion, which is also a big influence. So what we did is we started developing a protocol for a feasibility study in 4 female landrace pigs, which began by switching their diet to a liquid diet, including Dutch vanilla custard, and a period of laxation, starting 4 days before the actual treatment. Then at 12 hours before the treatment, we stopped the feeding and administered an anti-foaming agent to get rid of as much gas as possible. And then shortly before the treatment itself, we administered an antispasmodic to prevent peristaltic motion, which would have interfered with our thermometry. So additionally, we also designed a special gel spacer, which is placed on top of the HIFU window in order to displace bowel loops and give us better access to the pancreas itself. So as you can see down here, this is the pig without a spacer in between, and these are 2 different spacer sizes that we tested. In the end, we ended up using this 4 centimeter thick spacer, which gave us a lot better access to the pancreas in the end. With all this in place, we were able to start the treatment, and here you can very nicely see the temperature evolution during the treatment itself. And here in red and in white, you can see the thermal dose contours for 30 or 240 CEM 43 respectively, which we can already use during the treatment to make an estimation on how much tissue we already ablated. After the treatment, we performed a contrast-enhanced scan to verify the treatment volume and excised the pancreas, on which we then, after fixation, measured in gross examination the diameter of the ablated area. When plotting all these measurements together, we can see a nice trend that, depending on the energy that we apply during one treatment, we get a correlation with the ablated site, size of the ablated site, which basically tell us that if we implement an automated algorithm which can switch off the HIFU as soon as the treatment volume is reached, we can very tightly control the volume that we want ablated. So in conclusion, ultrasound-guided HIFU already shows great promise for HIFU treatment of the pancreas, but with MR-guided HIFU, we might be able to improve the situation even a little bit more. And to make more progress towards the goal of actually performing a clinical trial, landrace pigs are a suitable model. And what we need to succeed for this kind of safety and feasibility study is bowel preparation of the pig. We need bowel compression and displacement to get better access. And we need an antispasmodic to prevent bowel motion during the treatment. The last ingredient for success in such a study is, of course, a great team. So these people were all involved in setting up the treatments and supporting. So with this, I would like to thank them and my funding sources and you for your attention.
Thank you very much for the presentation. I already see the first question.
Yes, thank you for your presentation and the nice focus. And you removed the pancreatic, the pancreas, but you did not say anything about how selective you were. And in your imaging, you masked the rest, or you showed only the temperature increase in the pancreas. But there's also other tissue around. So what did you see when you did the autopsy of the pig? Whether there was also damage in the other tissues?
That is a very good point. Actually, so. These were not the first pigs that we treated. Maybe I should have gone into that a bit more in the beginning. But so there was a period leading up to these experiments where we were not yet sure what steps we needed to take to make sure that there were no bowels in the way. And what you're probably aiming at is that we can get very bad burns on the bowels themselves if they're in the beam path and if we use high powers. The way that we can prevent this is by performing low-powered test sonications, so something like 60 watts at a time, and observe if there is heating in the pancreas. If we do not observe this heating, we have to assume that there is something in the beam path. And since we have started implementing this protocol that you just saw, and the strict routine that we do not treat if we do not see heating right away, since then we have stopped seeing burns anywhere, neither on the skin nor in the bowels. Maybe some slight irritation now and again, but nothing dramatic.
So, but as I understand, all pigs were immediately sacrificed, yes? So, yes. So you do not know even a short time the adverse events of these procedures in reality, in the live animal, yes?
Yes, that is true. So this was purely a feasibility study and not a safety study.
Okay. Another question.
Thank you for that presentation. I'm not so familiar with the technique, but I would like to ask, could you also have problems with blood vessels, or is there protection by the high blood flow?
You mean that we could have problems reaching our target temperature? Or what is...
You produce complications, for example, by bleedings or so?
Oh, yes. Actually, that is part of the goal of the treatment, to devascularize the target area.
Okay, so I don't see more intermediate questions, so let's thank the speaker again.
Thank you very much.